do is open it up to questions and discussion. And John, what I ask you to do is I'll try to get the microphone to people to repeat the question.
Yep.
If you could. So start here.
Yep. Okay.
Thank you for all your work on trying to make it clinically comparable and everything else. One of the issues, I've done a lot of work on quality of life instruments and repeats over time with the same people. And one of the things, even when you use quite complex, I'm glad you got as long as an hour interview. We found there was a lot of learning that takes place, and it would depend how much time between a person seeing the instrument again. And so especially that would confound your interfaces as you switch, that if you've got a person who's been seen several times before in a previous setting, now they're going to be different from a person who's seen for the first time in a new setting. So it's just sort of an alert that your instruments may collapse and change in dimensions just from a person learning.
Yeah. It was a great question. It's the concern is about if you look longitudinally at data from surveys on quality of life, for example, that people tend to learn what the survey is about and start to answer in systematic ways. They remember what they said the last time and keep saying it that way. I think that's a fair description of the issue. In fact, our assessments are not self-administered assessments. They're assessments done by the case manager or the clinician, and he or she uses all sources of information available to that individual to make the assessment. So they interview persons directly, they talk to caregivers, they talk to other staff, they use charts, they use their own observations. So the observer is the rater. You do get different answers from self-ratings versus observer ratings, so there's that issue. We, in fact, spend a lot of time on training assessors to be, so that they are giving reliable and valid answers. We've got good evidence that they can get that. But an issue that's sort of akin to what you've raised is a debate about whether assessors should be allowed to see the last score they gave or not. My view is I'd rather have them blind to it. Our acute care docs in the interRAI group say, well, it's meaningful as the clinician to have, if you're going to observe the person over 4 points in an acute episode, to have each observation in the column so you can see where they were last. And they say, oh, well, no, acute doctors aren't biased by that. I don't buy it. I think they are biased by it. So we have a similar issue, but somewhat different implications there. Great.
Other questions or comments?
Hi, interesting talk.
Thanks.
What strikes me as kind of thought-provoking is the distinctions in different types of classifications. And if you use, and you talked about a number of different classification systems, everything from diagnostic-based systems to clinically-based systems. But if you used an example of, say, psychiatric measures, and you're using an interRAI instrument, and there's also other systems like DSM or ICD-10 or other classification systems. What's your comments on these multiple classification systems, and how do you derive something more consistent?
Well, the ICD and the DSM are classification systems for diagnostic typologies, whereas the case mix classification systems are grouping methods to group people in terms of their resource intensity. So in the SCIP system that we developed for psychiatry, we do use provisional psychiatric diagnosis as an organizing principle, but what we're modeling at the end is resource utilization in psychiatry, whereas DSM, I think, is a way of grouping people together in terms of similar clinical typology. So the purposes are a little bit different. But where it does get very interesting is if you've got the same person who's in 3 different settings. So in one case, they're in an acute hospital bed funded under CMGs. In that case, the hospital is going to get no money for them because CMGs are lousy at describing psychiatric resource use. But the good thing is they're not getting a lot of money, but they're in an expensive bed. Now, if they're in a nursing home bed funded on the Alberta Resident Classification System, they're not going to get a lot of money either because the Alberta system is driven by functional impairment and continence. And, if psychiatric patients tend to be more physically independent, and continence isn't as common a problem, so they're not going to get money based on that. Under the SCIP system in psychiatry, if they're a new admission with schizophrenia and showing behavior disturbance, that's the most expensive kind of person we found in psychiatry. So let's say we got that person in 3 different care settings. If they happen to be in a psych bed, under that case mix system, they'd be funded much higher than in the nursing home bed, and not as high as the acute bed, because acute care is already at a higher stratosphere anyway. And so, that's the sort of the issue of why people are sort of thinking, can we come up with a cross-sector case mix system? The challenge is that you see different groups of people in different settings, and the responses to clinical characteristics may differ in different sectors. Like what we see in home care is as soon as you see behavior disturbance, people get institutionalized. It seems to be the straw that breaks the camel's back of people getting into nursing homes. In long-term care facilities, as soon as you see behavior disturbance, they get them out of there because they're too expensive to go to, and they send them to psych hospitals. In psych hospitals, they're better at dealing with behavior disturbance. They can bring the symptoms down more effectively, and then they don't want to keep them there because they're a nursing home resident, and so they go back. So this person gets bounced around in different settings because the clinical response is different, the kinds of people that are typically there are different, and so it's going to be a very challenging issue to try to think about how to meld all these case mix systems together. I don't think we're going to see an answer to that for at least a decade.
Maybe I got to add a question, John. One of the things I've heard from people in the nursing homes, for example, is that the use of an assessment instrument like this is an add-on to what they do. And they collect similar information at other points, but then they have to capture it in a duplicate form. Is there any way where these assessment instruments can be integrated more into the normal data capture process, or that the assessment instrument data can be integrated into the clinical information?
Yeah, it's a great point, and there's lots of ways to implement this simply as an add-on. Like, by changing nothing else and just adding this in, you're increasing the workload. And so one of the things that can be done is get rid of other things that aren't used. So in complex continuum care hospitals, for example, I've yet to find anybody who's ever made a decision based on workload measures, because the workload measurement systems aren't very good. They don't tell you anything. And so one of the things when I worked with Providence Center in Scarborough that we did is we got rid of the workload measurement system and replaced it with the MDS and the RUG system. And so we took some things off the table. The other thing that we did there is, and we see it now in Homewood as well, is we did a review of all the other assessments that are being done. And what we found is that people are doing, dozens, probably in Homewood there's something like 60 different assessment forms being used, but not in a consistent way and not in any kind of a rigorous way. In fact, the only thing that's being used in a standardized way in everybody is the RAI mental health. And so what we've said is that you must do the RAI mental health. Everything else is up to you. You can make the decision to keep it or not. If you take it off the table, that's fine. And so, find ways to reduce burden on the clinicians is another opportunity. And the third thing I'd say is, this issue came up. The province is actively considering now whether to implement our nursing home instrument in long-term care because of some very high-profile quality problems that appeared in December. And so I've been having ongoing discussions with the Ministry of Health about this, and this issue came up. And my 12-year-old son plays basketball with a raptor ball thing, and so one day, he was playing basketball, and I was sitting watching him, and it was sort of classic kid sports. They had these, 10 kids on the court, running around in these little packs. The ball would be over here, and all 10 would be there fighting for the ball. The ball would squirt out, and they'd run over there and get the ball, and the ball would squirt out again, and they'd chase it again. And they weren't playing positional basketball. And I thought, well, what's the matter with the coaching here? They're not sort of teaching these kids to spread out and pass the ball. In some ways, it's the same kind of issue in long-term care. That when I read the Toronto Star articles about quality in nursing home, what I was reading about was staff members who were feeding a resident, and then a resident would act up, and they'd have to go manage that person, and somebody else had problems with toileting, and they'd have to go, and then they'd come back, and the person's food would be cold, and something else would go on. It felt like the positional play problem, that they weren't being organized in terms of the care that they were providing. Saskatchewan mandated our nursing home instrument in 1999. They have a lot less money than we do. Steve Levine from the Prince Edward Health District, though, told me that one of the things that their staff found is that even though they didn't have a lot of resources, implementing our system helped because it helped them to be more organized and more targeted. Because the clinical algorithms that we embed in the instrument help you to say, well, for this person, delirium is an issue. For this person, Pressure also is an issue, and for that person, depression is an issue. So you can focus on each of those and know that you've looked at and don't have to be concerned about those other things rather than not knowing where the ball is going to squirt next.
Interesting. Other questions or comments? If not, I have one more. I've heard part of this before, but I think it would be useful to hear it again. Is you use the term minimum data set and this instrument. You go through quite a process to create these. Could you just briefly describe that process?
Yeah. And people look at us and say, what do you mean minimum data set? There's two things we always hear the first time somebody sees our instruments. The first thing they say, it's too long, and the second thing they say, there's not enough about this issue. And so it's very interesting. The approach that we go to is we start off to say, what are the key clinical problems that any assessment instrument in this sector should address? So for the psychiatry instrument, we met with psychiatrists and frontline clinicians to ask them about this, and they started saying things like suicidality, criminal involvement, substance abuse, unemployment, family problems, and so on. And so we said, okay, here's sort of the top 20, top 30 clinical problems that any good assessment should address. Then the next thing we ask is, what's the minimum set of questions you can ask that will tell you that problem is present? So for example, around suicidality, we ask, has a person ever had a self-injurious attempt? Was the intent to kill themselves? Are other people concerned about suicidal behavior, and is the person having suicidal ideation now? We don't ask 90 questions. We just ask those 4 because a yes to any of those 4 raises a flag to say this person's got issues around suicidality. Now you need to ask a lot of questions there. So the minimum data set is always the minimum number of items to cover the domain area. We go through a painful process of trying to winnow things down to kick out stuff that clinicians will never use. And 2 examples that we had in psychiatry was one where it was Hirdes being a do-gooder. I sort of thought, well, literacy is an important problem. I sort of read the literature and, people are concerned about literacy. So we put in a couple literacy items, and in the pilot testing we found that clinicians hated the items and patients hated the items. We used Stats Canada's standard literacy item where what you do is you take an aspirin bottle and give it to Jeff, and Jeff reads it, and then you ask Jeff, tell me how you're supposed to take your aspirins. Well, what happened was Jeff systematically thought we were testing his compliance to medication, and so got all upset because the patients thought it was an adherence test. And the nursing staff thought this was a memory test, so they wouldn't let Jeff keep the bottle. They kept taking it away from him. Instead of letting him read the bottle for the literacy test, we found that one item on its own took 15 minutes to do. And so it was a disaster. We got rid of it. The other item that we had is we had a PhD level nursing researcher in our group who'd done her dissertation on the concept of engulfment. Engulfment is the state where your mental illness defines you as an individual. And it could be an important problem from a quality of life perspective. And so we said, okay, give us your 3 engulfment items and tell us how you're going to use it. It turned out the items were terrible. It created all kinds of problems. That they were asking people, do you feel damaged by your mental illness? Do people treat you differently because you're mentally ill? And do you feel your life is worse because of your mental illness? Terrible questions to use that just created all kinds of problems throughout the assessment. And as we looked at it, we said, well, the clinical decisions that we'd be interested in, we can pick up in a lot of different ways here. We can see, is a person having problems with social functioning or non-involvement in the community? And we don't have to have those items in, even though the researcher would like them, the clinicians just weren't on side. So that's how we've gone to try to reduce these to minimum data sets. And now, systematically, our assessments are somewhere between 45 minutes and an hour. And what we're finding is, as things get computerized, the assessment time is going down substantially.
Interesting. Any final questions or comments? If not, John, I want to thank you very much. Very enjoyable presentation.
Great. Thanks.
Thank you very much. And we have a little gift for you to take back to decorate your office.
Great. Thank you.
Thank you.
Thanks very much.
So if you want to take a few minutes to talk to people and talk to John, welcome.
Great.